Hello, hello. Good evening, everybody. My name is Keshi Muzoi from Nyandara Boarding Primary School alumni, and today's session is one that has been asked about by the ladies and their partners, and it's all about creating awareness about female um, reproductive health. And today's focus will, and first of all, today is our first health talk, focusing on uterine fibroids. And we welcome you all from wherever you are. First of all, I hope you're safe wherever you are. I hope that you're taking care of yourselves. I hope that you're indoors and your loved ones are. And as NBPS alumni, we're also doing an outreach. So if you have any problems or issues, please make sure you reach out to one of our officials or any platform that is helping people in need. So let's stretch out a helping hand if you can. And I know today there's a blackout, so you're there with us. There's noise sometimes in the background. The lighting will not be perfect, but we still had to do this session because we love you all and we want you to learn. So keep the questions coming, keep it engaging. And guess what? Today, as you saw on the posters, we are very, very honored to have great gynecologists who will introduce themselves very shortly, and they are there. You'll see them on your screen. We have Dr. Angela Anzeze and we have Dr. Paul Koigi. And mtatusamehea leo tunatumia torch, but we are here. So, doctors, please introduce yourselves and thank you so much for making the time. Mlituambia hata wakizima stima, we are doing this, and we appreciate you guys so much. So I'll allow you to introduce yourselves, and then you can start from there. Go ahead.
All right. Hi, evening, everyone. My name is Dr. Angela Anzeze. I'm a consultant gynecologist at KNH, and I'm also in private practice at Nelson Awori. It's just near Nairobi Hospital. And we're glad to have this opportunity to speak to you about a very common reproductive health condition affecting women, fibroids. And we apologize for the darkness, but at least you can see us, and yeah, at least you've seen our posters. So yeah.
All right. Hi, everyone. I hope you can hear us well enough this evening. Dr. Paul Koigi is my name, consultant obstetrician and gynecologist and head of Department of Research at the Nairobi Hospital, and consultant fertility specialist at the Nairobi Fertility Clinic at Nelson Awori building as well. And thank you so much for having us. We are insistent that hata kama wakizima taa bado tutakunywa masomo. Thank you.
Awesome. Thank you so much. We will be sharing more information about the two doctors. It's very hard to summarize everything that they do because they're just amazing and brilliant in their fields of work. So without further ado, I will just let them dive into the presentation about today's topic. So go ahead, Dr. Angie.
All right. So thank you once again. So I'll just talk about uterine fibroids, what causes it, the risk factors and the symptoms, and what to expect in pregnancy. And then Dr. Koigi will talk about how to investigate fibroids and how to treat. So most welcome, and please note down your questions as we go along, and we'll be ready to answer them. So what are uterine fibroids? This is a very common question we get from our patients at the clinic. And sometimes you'll note that they're diagnosed coincidentally, like it's an incidental finding. And most women actually don't know they have them. So this is a very common question. And when they get their ultrasound reports, they ask, like, what is this? So fibroids are non-cancerous growths that develop in and around the uterus. Actually, that's how they look like on the screen when you remove them. But yeah, they're basically non-cancerous, and there are different types. I image. Okay, sorry about that. So there are different types. So we have the subserosal ones. The image is gone.
Okay, it's okay. Looks like it's having issues with some.
Yeah. So we have the subserosal type, which is, I wish the image was there to explain it in more detail, but it's, so the uterus has three layers, the outer layer and the muscle layer and the inner layer. So the subserosal fibroid is on the outer layer. The submucosal fibroid is on the inner layer of the uterus, which is in the lining of the uterus, and that's the one that bleeds commonly. And the intramural fibroid is in the middle layer, which is the muscle layer. And the pedunculated is the one that's like sort of hanging off the uterus. I will share an image later to explain this, to be able to describe this in more detail. But basically, those are the most common types. And when you have an ultrasound report, these are the types that you get on the report. So at least this presentation will explain to you what that means. So what are the symptoms of fibroids? They may be asymptomatic if small, depending on location and size and number. And 30% of women will present with symptoms. And the most common symptoms are heavy menstrual bleeding and painful periods, longer or more frequent periods, pelvic pressure or pain, and symptoms of anemia due to heavy bleeding, such as headaches and dizziness. So this is what you'll experience commonly, but in majority of women, they're asymptomatic. Other symptoms include frequent urination or trouble urinating. You'll notice that your abdomen, like you're gaining weight, so your tummy looks bigger than usual. You'll experience other pressure symptoms like constipation, abdominal pain, and difficulty in conceiving. That's infertility, which occurs commonly. So this is just an image of a fibroid, a uterus with fibroids. So you'll notice the abdominal growth, and it looks like a pregnancy. Someone would think that you're pregnant depending on the size of the fibroid. So causes of fibroids include genetic. So there's genetic issues like deletion of chromosome 7. So you generally have 46 chromosomes, and each chromosome has its own function. So chromosome number 7 has been found in about 50% of fibroids specimen. So when fibroids are removed, they're taken, and when they're taken for histology, they're analyzed to basically determine if the growth that was in your uterus had cancer or not. And during this analysis, it was found that this chromosome number 7 has been found to be malfunctional in 50% of the specimens presented. Other causes are estrogen and progesterone. So these are hormones that we produce as females, and these hormones are known to feed fibroids. And when you have high levels of estrogen, we'll talk about that in the risk factors coming ahead, but when you have high levels of estrogen and progesterone, they cause growth of your fibroids. And this will be explained in the next few slides. Substances in your body that can cause growth of tissue, such as this is a substance in your body, and it's called insulin-like growth factor. And in normal circumstances, it causes growth of tissues. And in patients with fibroids, it's known to act on the fibroids and cause more growth of these fibroids. So those are the major causes of fibroids. I hope you can understand that. I hope it's not too much of medical jargon. So risk factors. So race, 80% of they're found in 80% of African women, and 70% of white women are likely to have fibroids. But Black women have a higher risk of having fibroids. So they are more common in the African race. Family history is also very strong. So if your mother or your sister, any close relative, well, mostly your mother or your sister, have had fibroids before, then you're at risk of getting them. Other factors include your diet. So if you eat a lot of junk, foods rich in cholesterol. We remember earlier on we mentioned that estrogen and progesterone are hormones that cause growth of these fibroids. So when you eat food rich in cholesterol, estrogen and progesterone are formed from cholesterol. So if you eat foods rich in cholesterol, you raise your estrogen levels. So you form that imbalance in your body, and that causes you to have higher estrogen levels, and therefore the effects of estrogen on the fibroids. So your fibroids grow more. So that's why we advise you that when you have fibroids, we advise that you have a balanced diet and eat healthy, and make sure you exercise to cut down on to reduce your cholesterol levels. The same thing that goes with obesity. It just means you have high levels of cholesterol, and which is converted to estrogen and progesterone, which feeds these hormones. Nulliparity just means that if you've never conceived, that's a risk factor. So having no children all your life predisposes you to fibroids, because usually in pregnancy, your body takes a break from menstruation, from the usual things that happen in your body. So when you don't get pregnant, the effects of the hormones continues in your body, and that predisposes you to having growth of the fibroids. Polycystic ovarian syndrome, I know it's a very common condition, and it's due to imbalance of your hormones. So you have more of the male hormone predominantly, and this also predisposes you to having fibroids. Hypertension is also a risk factor, and age at onset of menses, when your periods first started. So if the earlier you start, the more likely you are to develop fibroids because of early exposure of these hormones, estrogen and progesterone, and vitamin D deficiency. Complications of fibroids. This is a very common question that we get at the clinic. So the most common complication is infertility. So fibroids, depending on the location, commonly cause infertility depending on the size. So like I explained earlier, the uterus has linings, and the inner lining is where you conceive. So if that lining is blocked by a fibroid, it can prevent you from conceiving or basically cause infertility. Heavy menstrual bleeding, also depending on the location, they tend to cause bleeding. And the larger the fibroid, the likely you are to bleed more. And if you bleed heavily, you lose blood. And what happens when you lose blood? You get anemia. So your blood levels go below the normal level. Fibroids, big fibroids cause compression of the bladder, because remember, all these organs are just next to each other. So at the front, you have the bladder, and at the back, you have the rectum. So at the front, if they're so big that they're compressing the bladder, you are prone to having recurrent urinary tract infection and just a general feeling of difficulty in emptying your bladder or urinating frequently because of the pressure symptoms. You're also at risk of developing blood clots if the fibroids are large enough to compress major blood vessels because of their location. And so they tend to compress the blood clots that head towards the legs. So you're at risk of having lower limb or DVT, clots in your leg, in the blood vessels in the legs. And you're also prone to recurrent miscarriage, especially in the second trimester, because the fibroids are basically in the way of the pregnancy. So it disrupts the pregnancy. It can disrupt growth of the pregnancy, or it can prevent the pregnancy from going forward just because they're basically in the way of where the pregnancy should be. So you end up bleeding and eventually losing that pregnancy. However, in some circumstances, women do conceive with fibroids, and that alone has its own issues. So, like I'd said just now, you're at risk of having recurrent pregnancy loss or miscarriages in the second trimester commonly, and you may develop severe pain during pregnancy. Fibroids undergo degeneration, and this is called red degeneration. So they basically turn red because of the hormones of the pregnancy. So due to these changes, you start to develop pain, and it can be very severe that you need admission. And this is what we advise women when they come to the clinic who have fibroids, that you need to tell them early enough that the most common complication of fibroids in pregnancy is severe pain. And it can be very painful that you worry that maybe you're going into labor or something, but just to let you know that it's normal to have this type of pain. And once, if it's very severe, you're admitted and put on medication to stop the pain, and basically monitor throughout that admission until you're better. In some instances, it may lead to labor before term, which is called preterm labor, before the time has reached for you to deliver. Because remember, this is not a normal pregnancy. It's a pregnancy with fibroids. So you have your baby there and it's coexisting with the fibroids. So it can be very uncomfortable for the uterus. It can be very uncomfortable for the baby itself to coexist under such circumstances. And that's like your body will just react by saying like it can't continue. So you end up having early labor, or in some instances the baby fails to grow as it's supposed to, so you end up having a smaller baby or growth restriction. And in some instances you may have where the placenta is attached, because of the abnormalities associated with the fibroids, the placenta may give way from where it's usually attached. Remember, the placenta is attached on your uterus. It's like stuck on your uterus in a particular place. So in some instances, because of the fibroids, the placenta may give way from its normal attachment. And this usually, because this is traumatic, you end up having bleeding. And when you have this type of bleeding during pregnancy, you're at risk and your baby is at risk. So you end up having a preterm delivery, which is usually done as an emergency CS, cesarean section. Another risk is bleeding after delivery. So usually your uterus is supposed to be normal without any growths. But when you have these fibroids there, your uterus fails to go to its normal size after delivery. So when this happens, it's like basically I don't know how to say it in layman terms, but loose or flabby. It's not firm, it's flabby. So your uterus is supposed to be firm after you deliver because it's a natural response to your body to stop bleeding. But when you have fibroids, this firmness of the uterus is not achieved effectively. So it ends up being flabby. And when it's flabby, it bleeds. So you develop what you call postpartum hemorrhage. And this can be life-threatening. And I mean, of course, your doctor will do as much as possible to stop the bleeding. In some instances, even remove the fibroid if it's during a cesarean section and it's on the way of the baby. We can remove the fibroid, but this also increases risks of having you bleeding during that delivery. So we give you medication and we try as much as possible to stop the bleeding during the surgery. But in the event that the bleeding is excessive and it's life-threatening, we say that now we need to save your life, but the source of the bleeding needs to go. So a decision is made to remove the uterus. That's hysterectomy after delivery, and that's if it's life-threatening. Yeah. So that was basically it about my presentation. Apologies for this second slide. The image is missing, but it just describes the location of fibroids as this description. So maybe we'll post it after.
All right. Thank you, Angela, for bringing us into the subject of fibroids. So I think I'm going to share my screen because the presentation that we have is very heavy with very many pictures. So please, Keshi, please confirm that you can see the slides. Okay, I believe you can see. All right, so we'll start off.
Yes, we can see. Go ahead.
You can see, thank you. So we'll talk about the second part of today's presentation, and that is investigation and management of fibroids. So I'll give you an outline that will talk about why we do the investigations, the various types of investigations that we do, and the management principles, and the common types of treatment, and then we'll give a closing remark at the end of it. So why do we go out of our way to investigate patients who we suspect have fibroids? Number one, it is important to determine if the fibroids are present, and if so, we need to know how big they are, how many they are, and where they are located, because the size and the number and the location of the fibroids directly guide the doctor on the method of treatment to use to address the fibroids based on the needs of the patient. And secondly, it is also vital to determine how the other organs and organ systems have been affected by the presence of the fibroids in the uterus. Because as Angela mentioned earlier, the presence of fibroids in the uterus can make the uterus several times larger than it's supposed to be. And as a consequence, it can actually interfere with the relationship between the uterus and other organs in the body. And thirdly, it is equally vital to rule out any other conditions that can behave like fibroids. So, for instance, if a patient has another condition called adenomyosis, where the lining of the uterus leaks into the muscle of the uterus, it can actually become very big, like it has fibroids. But actually what is happening in that space is that the muscle of the uterus is being compromised by the lining that is bleeding into that space. So that's one of the most important things to rule out. So we'll start off with the specific investigations for other organs and systems. So to begin with, we'll start off with the blood tests, where you can do a full blood count, which tells you the level of your blood, because as Angela mentioned earlier, that when you have fibroids, one of the most important complications is bleeding. And bleeding can actually be severe enough to cause your blood level to go down very much. Secondly is coagulation profile, because with bleeding being so intense, it may become a problem for the body to be able to stop the bleeding. And thirdly, kidney function tests, because the fibroids can actually block the ureters, which are the tubes that direct urine from the kidneys to the bladder and can actually cause kidney failure. Then there are also thyroid hormone levels that we evaluate, because thyroid hormone in absence of fibroids can actually cause a very heavy menstrual bleeding. And then, of course, you had Dr. Angela talk about the concept of fibroids interfering with pregnancy substantially. And so that's why we would actually make sure that we do a blood pregnancy test. So in addition to blood tests, we also have other types of tests, and the two most important ones are stool analysis, because the fibroids can make the uterus swell backwards and interfere with the rectum. And if they swell downwards towards the anus, then they can actually compress the blood vessels that supply the rectum. And in so doing, they can actually cause hemorrhoids, and they can also be a risk factor for bleeding in your stool. And we also do a urine test for two reasons. But the most important reason for doing the urine test is because with compression of the bladder, there is a tendency to develop urinary tract infections. The other reason is that depending on how traumatized the bladder wall may be, it might also cause some bleeding to occur in the urine. So now we'll go on to investigations that will describe the fibroids. And the first one will be the ultrasound, which we consider as the gold standard. We'll show more about this in a little bit. Then there's also hysteroscopy, and then computed tomography, which we call CT scanning. And then there's also magnetic resonance imaging, also known as MRI. And that's actually the machine that is shown on the screen, and laparoscopic evaluation. So those are the 5 methods that we will use to investigate the fibroids. So we'll start off with the ultrasound, and ultrasound can actually be done transabdominally, which is where you take the probe of the ultrasound and put it on your tummy. And that's actually what we are seeing with the image on screen. So you can see here, this is the wall of the abdomen, and then you go down through the skin and through the muscle and through the fat. And then you see this is the urinary bladder containing urine. And then here we have all, this is the uterus. The normal size would be up to around there, but from here to there is the presence of a fibroid. And as you can see, it's pressing into the bladder. So this is an ultrasound scan that has been done through the abdomen, but we also prefer to perform the ultrasound scan transvaginally, which is where we take an ultrasound probe and we evaluate through the vagina. And the transvaginal ultrasound is actually better than the transabdominal ultrasound for giving us far more accurate images. It's kind of like the difference between how clear a picture is when you're watching on an older generation television versus when you're watching on the current smart screens, which can give you 4K or 8K resolution. So the difference between transabdominal and transvaginal is actually similar. So we prefer to do it through the vagina unless the uterus is so large that we end up having to do it through the abdomen. So ultrasound scanning is actually the gold standard for evaluation of fibroids. And thankfully, this gold standard is affordable and it is easily available. The reason why we call it the gold standard is that the likelihood of being able to spot fibroids if they are there is almost 100%. And the chances of being able to say that this patient doesn't have fibroids if you don't see them is 1%. So it's very accurate and it's very precise, which is why we say that we call it the gold standard. So then we have hysteroscopy. Hysteroscopy is where we take a camera and we put the camera inside the uterus through the cervix. So we'll show you a short video, which is on screen, talking about the use of hysteroscopy for diagnosis. And it can also be used to remove fibroids. So that's going through the cervix into the uterus. What you can see inside the cavity of the uterus is what we call a submucosal fibroid, what Dr. Angela mentioned as the lining of the uterus being visible, and the fibroids being visible through the lining of the uterus. And what you're seeing on screen now is a video where we use a procedure called this hysteroscopy, and we use what you call a diathermy loop to scrape off the fibroids on the inside lining of the uterus. So once you remove the fibroids, that's what they look like when you've scraped off the pieces of the fibroids. So as you've seen, hysteroscopy, where you're using special equipment, putting a camera through the cervix into the uterus, you can actually spot fibroids which are present inside the lining of the uterus. And once you find them, it's actually possible to remove the fibroids which are on the inside of the lining of the uterus. So now we have CT scans, and CT scans are actually not as commonly available as ultrasounds, and they're actually about 15 to 20 times more expensive than ultrasound scans. And they are therefore not often used to diagnose fibroids. But in the cases where somebody was not necessarily complaining of abdominal pain or the presence or knowing that they have fibroids, and they have another problem, say, like now in this case here, where we have this huge fibroid, which you can see from the side, that you can see that the fibroid is pressing on this tissue behind here. So this tissue behind here, these are intestines. So this is a patient who came with a history of having difficulty being able to pass stool, and that's because the intestines were being blocked. Back here, you can see the kidneys. And if these fibroids actually grew much bigger, then it's actually possible for the fibroids to not only compress the tubes that are bringing the blood, the urine down to the bladder, but it's actually possible for the fibroids to compress the kidneys themselves. And so this is when the patient is lying on her back, and this is lying from the side, and this is when she's lying on her back, but you're looking from below. And you can see here the bladder being full of urine, and this is the uterus. And this is a fibroid which is turning very white because of something called calcification, because in some cases, fibroids can start breaking down by turning into hard-like substance that's hard like stone, and we call that calcification. So then we also have the MRI, which was magnetic resonance imaging, which is even more expensive than CT scans. Having an MRI scan can actually be about 30 times as expensive as an ultrasound scan on average. And just like CT scans, they're not often used to diagnose the presence of fibroids, but they can help diagnose complications. And then we also have something called laparoscopy, where, as you can see on screen, we make some small holes through the abdominal wall, and we go into the abdomen to look at the uterus from inside. And here we can see some fibroids in the uterus. So once we make those small holes in the tummy, we use this special equipment. And the most important equipment is the camera, because it enables you to see. And then we put in the other equipment that we can try to use to find and remove the fibroids, if they are not too many. So like this patient only has 4 clear fibroids that can be seen very well. So it should be possible for this surgical procedure to have been able to remove these 4 fibroids. Then we also have, once you've investigated this patient for fibroids, we now try to decide what to do. So in the process of deciding what to do, there are 2 levels of treatment that we offer. If you remember in the beginning, we talked about the tests that look for damage to other tissues and organs. And those, when we deal with that and with some of the symptoms of the fibroids, we call those supportive treatments. And one of the most important supportive treatments is replacing lost blood. As you remember, Dr. Angela mentioned that the presence of fibroids can directly lead to extremely heavy bleeding. And extremely heavy bleeding is actually one of the most common symptoms of fibroids. And if the bleeding is very severe, rather than letting the patient go into heart failure, you will want to give this patient a transfusion, which is where you take blood donated from somebody else and give it to this patient. And once you've done that to bring the blood level up a little bit, then you give her some supplements so that you can continue to build her blood levels. And then the second thing is that you want to look out for and manage any other organs with issues. For instance, if there's a problem with the intestines, please send this patient to a gastroenterologist. If there's a problem with a kidney being compressed, you could send to a kidney specialist. If there's a problem with the pancreas being compressed, then you can send this patient to an endocrinologist, and also consider preparing this patient for surgical treatment. Then the specific treatments for fibroids are also available, which is now what we call the tendency towards definitive treatment. And the first group of treatments that we have is medical treatments. And then after medical treatments, we also have surgical methods where we can do the laparoscopy, which we showed earlier on the other slide talking about diagnostics. And then we also have the option to do something called a laparotomy, which is where we make a cut on the abdomen and open up the abdomen. So laparoscopy is where you use the small keyholes, and laparotomy is when you've decided that the fibroids are so large that it will not be safe for you to use those small keyholes to treat. So in that case, then you can do a laparotomy. And during the surgical management, the options are two. If the patient is desiring fertility, or if she wishes to preserve her uterus, or if the fibroids are few and they're relatively small, then you can focus on removing the fibroids. However, if the fibroids are so large and they're causing so much bleeding and compressing so many organs that the life of the woman is in definitive risk, or if she is of older age and preferably if she has managed to complete her childbearing, then in such cases, we would actually recommend removal of the uterus, because the removal of the compressing agent will actually lead to resolution of all the symptoms. And then we have other newer treatments like uterine fibroid embolization. So we'll give examples of all these treatments. So for the medical management, we have painkillers, because fibroids come with a lot of pain a lot of the time. And we usually give at least 2 painkillers if the pain is moderate. And if the pain is severe, we can actually give even 3 different types of painkillers. Secondly, we can give medications to reduce blood loss. And these medicines that we can give to reduce the blood loss are done in the hope of trying to shrink the fibroids so that we minimize the interference with the lining of the uterus and therefore reduce the bleeding. Thirdly, medications to reduce the size of the fibroids. And fourthly, we also have one of the newer medical managements in which we insert an intrauterine contraceptive device, or also known as a coil, that contains progesterone. And the thing about giving a progesterone coil is that it will prevent the lining of the uterus from becoming very thick, so that even when it is time for this lady who has fibroids to have her periods, because the lining is not very thick, then you don't have much of a lining to shed. And as a result of which, you may be able to reduce the bleeding. And in some cases, the presence of the progesterone being higher than the estrogen might actually lead to some shrinkage of the fibroids. Then we have surgical management. And within the surgical management, we have So that procedure that we've just demonstrated in the video is called a myomectomy, where you are removing the fibroids. And as we saw at the start of the video, there was an injection that was put into the uterus around the fibroid, and that is a medication to shrink and tighten the blood vessels so that you reduce the amount of bleeding that happens during the removal of the fibroids. And then if it's not possible to remove the fibroids and the life of the mother is in danger, we may actually opt to do a hysterectomy, where we're actually talking about removal of the uterus as a whole. And then we have another procedure known as uterine fibroid embolization. Yes, so that is uterine fibroid embolization, which is a procedure that is used to block the blood supply to the fibroids. And the advantage of that is that since fibroids actually use blood and oxygen and nutrients to grow, if you block the blood supply to the fibroids, then they will definitely shrink. And in a good number of cases, the fibroids actually die. However, as the fibroids die and as they begin to shrink, it's the equivalent of having a piece of the uterus dying inside the uterus. And this can actually cause a lot of pain because the fibroids start beginning to break down. And as the fibroids break down, then they can actually cause a lot of pain. What Dr. Angela had talked about as degeneration. And that degeneration is because now the blood supply has been compromised, but it does lead to shrinking of the fibroids and does lead to reduction of the bleeding. But because it damages the wall of the uterus in the long run, we actually don't recommend this uterine fibroid embolization for patients who are considering getting pregnant. Because if you want to get pregnant, you want a good living healthy wall with no parts that have got issues or like pieces of it that have died inside it. So that procedure is preferably for people who are not in the process of trying to have a baby. So we have a couple of take-home messages from Dr. Angela and myself, and that is that uterine fibroids are extremely common, especially among Africans. Theoretically, it's about 10% more common in Africans than in other races, although in practice it might actually be another 15% over and above the frequency in other races. Secondly, there is actually hope for women with fibroids because there are actually legitimate treatments available. But for those treatments to work, please look for treatment early so that we can work together to ensure the best possible outcomes. So I think that will be the end of our presentation. So I think that is the end of our presentation. Thank you for your time and your attention. We invite you to follow us on social media because we do a lot of teaching on our social media platforms as indicated on screen. And I think that'll be the end of it. Thank you very much.
Wow, wasn't that insightful or what? Asanteni sana, Dr. Angie and Dr. Koigi. And on the comment section, I see we have a lot of questions that were also sent prior to the session, so I'll just go straight into it. And the first one, it goes, I'll just project it on the screen just for a moment. I make it easy for us to read. Yeah. So there is, just a moment, yes. So as Dr. From 2022 August, I was diagnosed with ovarian cysts, but later this year I took an ultrasound and it has dissolved. I took another test for hormones and they are imbalanced. I have been missing my periods too since August 2022. I have been trying to conceive without success. I have a lot of fertility meds without success. I have never been pregnant before. The last meds I took were Glamagy. I used different family planning before. What should I do?
All right. Thank you for that question. Now, ovarian cysts are actually a very common thing inside a woman's body because the eggs develop in ovarian cysts. So every month, there will definitely be a cyst. And if the cysts are many, then we call them polycystic. That's why there is a condition called polycystic ovarian syndrome. And if the cyst was there in 1 month, and then you did another ultrasound scan again after at least 2 weeks, and that means that the cyst which was there was carrying an egg that developed, and a process called ovulation occurred, and the egg was released. So the cyst disappeared. So it's not that it was a misdiagnosis, it was just dependent on the timing of the cycle. Number one. Number two, because this question had multiple questions to it. So the hormones being imbalanced is actually a very common diagnosis for a lot of women, because if the hormones are not going in order, so that you can have estrogen and progesterone being produced at specific amounts by the ovaries, so that the lining of the uterus can respond in a specific way, so that you can have the lining grow, the lining prepare to accept pregnancy and either get pregnant, or when you don't get pregnant, the lining is shed. So in this first question's case, I think that there's a probability that the condition that she's suffering from may be known as polycystic ovarian syndrome, because it leads to the presence of many cysts in the ovaries, and it also directly leads to the lining of the uterus not being shed regularly, which will result in her missing her periods consistently without her being pregnant. And in event that she had taken family planning methods before, on average, family planning methods don't cause difficulties in conception, but if somebody has been taking things like P24s, when people are in college, there's a tendency to consume P24 like groceries over the weekends, especially from Friday night and Saturday night. And when those are taken in very large numbers very frequently, then there's a tendency to have an increased risk to developing an ectopic pregnancy, but it doesn't make someone fail to get pregnant. The only one that has a little bit of time before what we call resumption of fertility or the ability to conceive is what is known as the 3-monthly injection or depot. That one can take a bit of time before somebody manages to get pregnant. So I think, I hope that has answered the question. And as far as the desire to get pregnant is concerned, please do come and pay us a visit. I think we mentioned where we are located, and we will be readily available to offer you the assistance that we can provide.
Asante sana. You wanted to add something, Dr. Angie?
No, I was ready to answer the next question.
Okay, great. So let me just read, just in case. So it says, hi, I would like to know the reasons why I get UTI, yet I don't have any symptoms, no itching or pains. Kindly advice.
So UTI is a bacterial infection in the urinary tract. So that's the bladder and the kidneys. It depends if you're pregnant. Pregnant women are at risk of having recurrent UTIs. It depends on if you have any underlying issues, and generally environmental factors. So public toilets, hygiene issues, and it can be asymptomatic, meaning no symptoms. But when you go to the doctor and they check your urine, it's incidentally found. So in such situations, we recommend that you treat, regardless of whether you have symptoms or not. Yeah. So unfortunately, women are more likely to get UTIs compared to men just because of where the urine comes from, which is the urethra. It's shorter in women compared to men. The urethra is like the opening at the front where the urine comes from. So it tends to be shorter in women. So if it's short, it means the distance the bacteria has to travel is shorter to the bladder. So that's why they're likely to get UTI compared to men.
Okay, so we have a comment from Edith, and she says that she's treating anemia because of fibroids. So I just wanted to ask, in that situation, like what foods would you recommend for her to, restore her body?
So when you have fibroids that have symptoms like heavy bleeding, you tend to lose a lot of blood, and what you lose is iron. So you need to replace your iron levels by eating foods rich in iron. So iron deficiency is what causes this anemia. So you need to replace your iron levels by maybe taking supplements that contain iron, and that's in mild cases. That's when you don't have any of those symptoms. So if you don't have like difficulty in breathing, severe headaches, dizziness, chest pain, those are the severe symptoms of anemia. That one needs blood transfusion. But if it's mild, where you just do a lab test and it's noted to be below 11, for example, so you just need to replace that iron that's deficient. So foods rich in iron, things like liver, green vegetables, and also iron supplements to bring up your iron. Yeah.
The next question is, at what stage do you consider a hysterectomy?
Right. Thank you for that question. So hysterectomy, as we mentioned, was the removal of the uterus. And we actually consider removal of the uterus in several specific cases. Number one, if the woman and the woman and her spouse have determined that they have had enough children and they don't want to keep on going through the treatments for fibroids, it's because the fibroids will have a tendency to recur even if you remove them, then such a person may sit back and say, you know what, I don't need this drama, I don't need this grief, let me just get this uterus out and stop experiencing this pain and this bleeding and all these other symptoms. The second group of people who may want to have a hysterectomy are the people who are, particularly those who have reached menopause or they are well beyond childbearing age, because well, the typical purpose of the uterus is to carry children. And if the uterus is bringing issues because of a problem within the lining, once you make sure that you don't have a cancer present, then you can just remove the uterus. And removal of the uterus can actually happen with a few extensions. In some cases, if there's a suspicion or confirmation of cancer, you may have to remove the uterus, the ovaries, the tubes, and a little bit of the vagina and some of the other tissues, but the extent of that depends on whether or not there is cancer. Then the third group of patients who may need to have a hysterectomy would be, for instance, the patients that Angela was mentioning just now, that patients who are in a space where the fibroids are so big and they've damaged the uterus so much and they're compressing on all the other tissues and organs, that you will basically essentially be removing the over 90% of the structure of the uterus. In such a patient, in order to save her life and reduce other complications like the difficulty in breathing, difficulty in passing urine, difficulty in passing stool, urinary tract infections, and developing blood clots and so on, such a patient would actually benefit from having the entire uterus removed. So I think those are the most common situations. There are a couple more, but I think for the purposes of this audience, these would be the best.
I think you can take the next one. Is it advisable to do a hysterectomy during childbirth?
Let me answer that one with a very unfortunate wololo. We don't advise doing a hysterectomy by choice during childbirth, because you see, when a woman gets pregnant, there are adaptations that occur in the whole body to make the body of the woman be able to tolerate the pregnancy. One of the most important changes is that the uterus will increase by up to 20 times, 10 to 20 times its normal size. And when it's increased by those 10 to 20 times its normal size, the blood supply to the uterus reaches a point where it becomes the organ taking the highest amount of blood in the body, which means in the span of a minute, when the heart is pumping out blood, 20% plus of the blood being pumped out from the heart can go to the uterus to accommodate the pregnancy. So if the blood level has been increased by up to 20 times, then if you are insisting on removing the uterus during childbirth, then you're going to risk having an extremely high amount of bleeding. Not only that, for that reason, we actually sit back and say that the only time we remove a uterus during childbirth is if there are complications that have happened that have made it so difficult to be able to try and save that uterus. For instance, if the woman has bled severely because, say, for instance, the presence of fibroids, or if the uterus is refusing to contract, which can also be caused by the fibroids, or because of difficulties in have things called coagulation factors, which is what helps the blood stop, or because of trauma, which can also be, the risk can also be increased by fibroids, then in such instances, those are the patients who we actually accept to have the uterus removed. However, if the fibroids have been properly managed and you've managed to remove them before she gets pregnant, then we are likely to have a safe delivery and we are less likely to remove that uterus during childbirth. If a woman is going to need to have her uterus removed, we strongly recommend that if she wants to remove it after delivering her baby, it should be after at least 6 to 12 months, so that the uterus has gone back to the non-pregnant state. Then we can talk about having a safer removal of the uterus.
Thank you for that. So there's this question that I'll tie to another one that's almost similar. Is there a natural way to safeguard yourself from fibroids? And the other one says, are there early signs, or how do you detect them early?
Okay, so I'll answer the first question, whether there are early signs. So in some, like I'd said earlier, some women do not have symptoms. So they usually identify them incidentally, like when you're sent for a scan, and then that's now when you find out you have fibroids. That's when they're small. But as they continue to grow, you will now develop those symptoms like heavy bleeding or pain during your periods. Like the pain can be very severe during your periods that you're not able like to go to work. You're not able to function. If you have such painful periods, please visit a gynecologist, because that's not normal. Any period pain that makes you not do anything, not go anywhere, stuck in bed all day, like a pain score of 9 out of 10 or 8 out of 10, that's very unusual. And it's good to have an ultrasound done, because that could be an early sign, or rather a sign of fibroids. So heavy bleeding is also another sign, and anemia, and things like constipation or difficulty in passing urine, like you feel like you're constantly need to pee. Like you go to the loo and then after a few minutes you feel like you have to pee again. So that's a very common pressure symptom. Yeah, so those are the most common symptoms one would experience with fibroids. So yeah, you can detect them early if you go for your regular, maybe annual checkups. Please ask for an ultrasound, and that should be able to detect it early enough.
All right. I can also answer that question on whether there's a natural way to prevent the growth of fibroids. To be honest, not really. And one of the biggest risk factors that Dr. Angela mentioned previously in the risk factors was taking long to get at least that first baby. Because if it takes very long to get pregnant, because the uterus is meant to carry and have tissue, something growing inside it. So if there is no baby growing inside it, then the risk of something else trying to grow now in the form of fibroids increases, probably by another 30% or so. So we don't honestly have natural methods of safeguarding oneself from fibroids. And I would like to say the very important disclaimer I want to give is that we don't have any supplements or herbal medications that can reduce your risk of developing fibroids. So I would like to please beg, as early as possible, please don't stay at home taking some of these other now famous herbal medications that are being advertised all over the place. Only that I can't go around mentioning names directly. But please don't take them. Please come look for medical treatment, because when we diagnose the problem early, we can treat it early enough before the risk of other complications arises. Thank you.
So we're almost wrapping up our Q&A session, and we have a question from Kate Mugambi. She says, you comment on the medical treatment. What informs that option compared to surgical? Is it true that those used are the family planning hormone? I didn't get that last part, but I think you get the gist of the question.
Okay, so medical versus surgical. So it depends on is the patient ready for surgery? Is she psychologically prepared? Does she want the surgery? So if she doesn't want the surgery, if she's not psychologically prepared, if she's not ready, then medical treatment would be an option. However, it's more of a temporary solution, because the medical treatment is also temporary. Once you withdraw the medication, the fibroids grow back. So it's mostly recommended in patients who have very large fibroids, and performing surgery at that particular point would be risky for the patient. Like, the bigger the fibroids or the more the fibroids, the higher the risk of heavy bleeding during the surgery. So we give it as a temporary measure to reduce the size of the fibroids in preparation for surgery later, or in patients who are just not ready for surgery at that particular point. But note that it's temporary and the side effects can be very harsh. So we rarely recommend it. We recommend it selectively. Yeah, because it gives you side effects of like someone who's going through menopause, because it completely shuts down the hormones that feed these fibroids. Remember, we said estrogen and progesterone feed these fibroids. So when you give that injection, it suppresses them. So when it suppresses them, you go into like menopause, because all the other functions of these hormones are shut down. So you stop having your periods, you get hot flashes, things like that. So, but it's temporary. Once the medication is out of your system, you go back to your normal like factory settings. And the fibroids grow back again. So it's temporary. Medical treatment is temporary. Yeah. So we recommend surgical treatment all the way, because it's, well, if you're doing a hysterectomy, it's permanent, because you're removing the fibroids and the uterus, because fibroids grow on the uterus. So if you're removing the uterus, you will not have fibroids ever. Yeah. As far as myomectomy or removal of just the fibroids is concerned, there's risk of recurrence. So if you're a patient who has fibroids and wants to conceive, but you can't conceive because of the fibroids, we say you come, we remove the fibroids, and then after at least 6 months, after your healing and all that, we recommend that you conceive before they grow back, because they will grow back after, on average, depends, but on average 1 to 3 years. So within that time of removal, we recommend that you conceive within after 6 months of removal. Yeah, I hope that's clear. I hope it's not too much to take in, but yeah, those are the options.
Thank you so much. I think this is our last question, which I also wanted to ask. So, does the removal of the uterus mean that you're automatically fibroids free, or can you go through all that and still have issues? And so also wanted to ask, once that surgery is done, what complications arise out of that, and how do you manage them?
All right. Thank you for those two questions. I think the first question on screen had been partially answered by Dr. Angela. I think the reality is, if you remove the uterus, you've removed the source of the fibroids, because fibroids develop from the tissue in the uterus. So if you remove the uterus, that's the end. You cannot have more fibroids. But the real issue is that you can actually remove the uterus and still have issues if, when the fibroids were there, then we do need to take into consideration that the fibroids may have been compressing on other tissues. You remember earlier we talked about compression of the bladder, compression of the ureters, and compression of the intestines. So sometimes the part of the intestines could have been compressed so much that part of the intestines died because of lack of blood supply and lack of oxygen. So it wasn't able to do its work. So you had to cut off part of the intestines and bring the remaining part together. So that's an example of another complication. Or kidney failure developed, or hormonal issues arose, and then you ended up needing to be addressed by a hormone specialist. And of course, for patients who have diabetes, then of course there's the consideration of the fact that with all the bleeding and all the recurrent tendencies towards developing infections, even after removing the uterus, for patients who are in that particular space, they have a high risk of developing infections. And when removing the uterus because of fibroids, usually you're very lucky if you can actually get the uterus out with everything else intact, if the anatomy is relatively okay. But if tissues have been distorted, if the tissue is not looking the way it's supposed to look inside the abdomen, then the risk of injuring other tissues is high if the tissues have been displaced. So you might injure the bladder, you might injure the ureters and therefore cause kidney damage. You might injure some nerves every once in a while during the process, depending on how extensive the surgery has to be. And also depending on how extensive the procedure is, there are things called lymphatic vessels, which carry the fluid from the tissues that's outside of the blood vessels back towards the heart so that it goes back into the blood system. If those get damaged, then you can actually get swelling of the legs. For some people, depending on the degree of damage, that one may resolve over time. For some, if it was extensive removal of that lymphatic tissue, then there's a good chance that that swelling may tend towards being permanent. So those are just some of the more important complications, but there's one other complication that we will mention, in that for surgery which is happening deep inside the body, because the uterus is inside the pelvis, which is in a very deep portion of the body. If the surgery takes a long time because of it being complicated, then there is a risk of developing blood clots in the legs. And we call that a DVT, which is short for deep venous thrombosis, which means clotting inside the veins. And that clot inside the veins can make the legs swell, can cause a lot of pain. But the most significant risk of that clot inside the vein is that that clot can break and go back into the heart, and then go to the lungs, and then prevent the lungs from functioning. and that is a life-threatening complication called a pulmonary embolism. This is one of the reasons why we are insisting, please come early the minute you feel that you are not okay. Don't wait until the problem escalates into a catastrophe, and then we end up having to incorporate so many other people to address it. So there's actually a lot of hope to address this issue. And there's also a lot of hope for those who are having fibroids and are hoping to get pregnant. And the hope is higher the earlier we get to have the opportunity to treat the problem.
Thank you so much. I don't know about you all, but I've been taking notes and I've learned so much. And thank you so much also to everybody who sent in their questions in advance. You made the session more lively. And also those who are engaging with us in the comment section, Asante Sana. So I'll just project maybe a few comments. We have, let me see, Onesimus Mbao said he's following. Thank you so much. And then we also had Edith watching from Kericho County. And we have Betty who said we'd like to have you back again. Yeah, and the last comment from Betty, she says, yeah, we'll share your social media with the people. And I follow our pages and BPS alumni pages. We've been sharing our socials there, and we'll also share the Dr. social media platform so that you can follow them. And once the session is wrapped, you can still go back and watch and take notes, and feel free to book an appointment with them, because this was just scratching the surface. There's so much more, and that we've advised. Always book your appointment so that you don't rely on hearsay or anything, but you have confirmation from them. And yeah, we appreciate you, Dr. Angie. We appreciate you, Dr. Koigi, for making time. And this is very entertaining because mnamulikana hapo na mimi nilikuja watu wasifikirie mi ni deep state ati niko na stima. Hatuna stima. Yeah, we had to make this session happen. We said we are not going to cancel it. So thank you so much for making time and doing your research and putting up the presentations. And I hope everyone has learned something. So I'll just give you and Dr. Angie and Dr. Koigi maybe 1 minute to give your final comments, and then we'll wrap this session.
All right. So once again, thank you for having us. And we hope all this information has been helpful to you. If you have any doubts, please feel free to ask us questions. And we hope through this discussion that we are encouraging you to always seek healthcare. Go to your gynecologist, have your checkups, and you're also welcome to come to see us. Have your checkups regularly to avoid having complications turn up too late. Yeah.
All right. Thank you so much for the opportunity to have had this chance to sit and talk about uterine fibroids. It's actually a problem that is present in almost 80% of women. And as was mentioned earlier, up to 30% develop complications of the fibroids. So it's a very common problem, and we are looking forward to having the opportunity to addressing these problems with each and every one of you individually. We are very much available, and our social media handles will also be made available so that you can be able to reach out to us. And we are looking forward to working to make sure that we optimize our reproductive health outcomes together. So thank you so much for being with us and for having us over, even in the midst of the national power outage. Yes. So for our Instagram handles, my page is at Dr._Paul_Koigi, and Angie's is Dr. Anzeze. On Facebook, she's Doc Angie Anzeze, and I am Dr. Paul Koigi. And on LinkedIn, she is Dr. Angela Anzeze, and I am Dr. Paul Koigi. So I think those are reasonably easy social media handles. We are definitely reachable, and our contacts are actually available on those social media handles. So please do feel free to reach out to us. We will be more than happy to take care of you And for those who are looking for fertility treatment, then we definitely have options available. I think in front of you is a team that can work to help you get pregnant, and then the other one subsequently manages the pregnancy. And we hope that you will have the best possible outcomes now.
Asanteni sana, and I think everyone agrees that we need to bring you back again. I hope that we'll have power then, and I know the issues, the topics to discuss are very diverse and wide. So we just started the health talk with the uterine fibroids, and so in future sessions we are going to do a poll, and you the audience will let us know which topics you'd like our doctors to address. So if you have any further questions, as we've said, we'll post the social media platforms on our socials, and you can access the doctors there. And thank you so much. We appreciate you all. And Mercy says, very insightful. Asanteni sana, from Nyandara Boarding Primary School alumni. We wish you all a lovely night, and please stay safe. I know it's raining, there's a power blackout, so please stay safe, and we'll be in touch. Let's engage on our socials. Good night.